Well, thank you very much, Dr. Parag, for the kind introduction. Thank you for the whole Pune team. I've been visiting your very high-level course for a couple of times now, and this year the world is different. And for all who are watching this webcast, I wish you health in these difficult times, of course. And this is the new way to teach. And this webinar series of the Pune knee course is a very high standard. So I was honored and privileged to be working with the team again now in a webinar. The first topic we're going to address is on advanced planning. And the advanced planning is more a continuation of the planning session that was beautifully given by Dr. Christian Klei, whom I work with together with Adrian Wilson, who was also in the first session on osteotomies 2 weeks ago. And also Ragbir Kaka is of great help in the London Knee Osteotomy Center. So actually I'm working in 3 centers. My only profession is deformity correction, and that's what I like most. So that's what I like teaching about too. First, we're going to start about advanced planning. Now, if we continue from the last time, the very important things already mentioned then are x-rays. If you can get a hold of an x-ray department technician who can make these kind of x-rays, long leg x-rays, that's mandatory for a proper planning of osteotomies around the knee. And if it's not possible to do that in your hospital, please find for these cases where you really want to try a good correction, specifically in advanced corrective surgeries, try to find a center in your neighborhood where they can make these x-rays. And the x-rays should be made by someone who knows how to make these x-rays. So instruct your technicians. This is on the left side, an incorrect positioning with the patella not forward, but patella pointing outward. At such a position, you will not have a good x-ray for your correction planning. So you should have the patella facing forward, whatever the position of the foot looks like afterwards, because, and we will see examples of that later on, you can have a rotational deformity of the lower leg. Then patella forward means that the foot points very much inwards. And that's if you want to correct the frontal plane, so varus valgus in such a situation, you can only refer to a patella forward view. So on the right, you see a corrected foot position with patella forward position, and that's what you always should ask for a full leg weight bearing x-ray, where you make your planning. Now, also correct for leg length. This is all illustrations out of the Bible of deformity correction by Dror Paley. You see that there's a height wooden block under the foot, and this will be important if you have leg length differences to make a good planning x-ray. Also important, any kind of ruler or calibration bullet like in this x-ray, then you have calibrated x-rays. These are the mandatory steps if you want to do a proper planning for your deformity correction. Now, you have seen this, and I will go fast. This is the analysis of the deformity according to Dror Paley. It has all been given to you already in the presentation by Dr. Klei 2 weeks ago. It is deformity analysis according to Dror Paley, and this animation has been made together with Stefan Schreuter, a good friend of mine and colleague in deformity correction from Germany. Here we are, we draw the lines, the mechanical axis are we using, and we can make angles around the knee, the mechanical lateral distal femoral angle, which normally measures 88, and the medial proximal tibia angle, which is normally 87. These 2 angles are very important to remember around the knee. Then you have other angles, the lateral distal tibia angle, the mechanical lateral proximal femoral angle, but we don't use these angles very often. Then you have, of course, the mechanical tibiofemoral angle, and then the joint line convergence angle. In the webinar 2 weeks ago, this was extensively explained by Dr. Klei, and I think he gave a good presentation of all the importance there. If you have an opening of the joint or an obliquity of the joint around the knee, you have to address that. You have to address that in your deformity analysis. You have to recognize it, but also address that in your deformity correction. Otherwise, you will end up with an overcorrection caused by the negligence of ligament laxities, which add to deformities. Or you will end up with a joint line obliquity because you didn't respect that besides a deformity in the tibia, there was also a deformity in the femur. Let's go to planning of an open wedge HTO. I just go fast. This is Fujisawa point planning. This is an open wedge, and you can just draw your lines and measure your angles. And I will go a little bit slower in this case. Mechanical axis of the limb, big varus. We want to go there. We want to have a weight-bearing line after the correction that passes just lateral or central to the knee. This is not much of a medial osteoarthritis. This is just a deformity. We draw our lines. We measure the angle between the old ankle center and the new ankle center. And then we project this angle on the medial proximal tibia, as this is a tibia deformity and not a tibia plus femur deformity. Then final step, if you have a calibrated X-ray, you can make a measurement on the medial side what the height is of the osteotomy gap. That's what I take into the surgery. That's what I want to know. After my planning, I know how many millimeters I have to open to correct so that the weight-bearing line will pass at the exact right point. And that will give me this correction in this patient. Anyways, from there, you can also do closing wedge distal femoral osteotomy planning. This has all been given by Dr. Klei last time, but just to show you that the same Miniachi type of planning works in the femur too. You just gonna make a new femur center, femoral head center, and from there you draw your lines and you measure your angles, and final step, you measure the height of the wedge to take out in a closing wedge distal femoral osteotomy. Now here's the importance of deformity analysis. This is one of the Abu Dhabi practice patients, big varus, and as already stated by Dr. Klei last time, if that weight-bearing line passes outside the knee, you have to be careful. There might be a varus also present in the femur, and it is, in this case, femur and tibia. So here you see that no way that you can only correct this in the tibia, you have to correct it in the femur as well as the tibia. This was a lateral closing wedge, and the wedge taken out on the lateral side is inserted in the open wedge of the tibia on the medial side. This is the post-operative X-ray, and this is the post-operative digital picture of the patient from Abu Dhabi. Now, let's move over to advanced planning. This is the surgical plan concept. I've written about this in the years 2008, and it's based on Schatzker's book on the rationale of fracture care. And if you look in that book, you will find similar build-up of a surgical plan. I've adapted that surgical plan method to osteotomies, and since then I've worked with it, and especially in advanced osteotomies it's very important to follow such a plan. So I hope that you're interested to learn about this, and let's go over step by step. First part of the surgical plan is a physical examination. Then you have your radiological deformity analysis, and of course the complaints of the patients and the whole history come before this, but this is for planning, these are the most important steps. And the radiological deformity analysis in any plane, frontal, sagittal, as well as transversal plane. And we will see examples of that through the other presentations and through some case presentations later on in this presentation here. Very important step is to correlate physical examination and your radiological deformity analysis. You cannot have an X-ray as the only thing to work with when you start doing your surgery. We should be careful with that. If you haven't examined your patient, you cannot correlate the examination, where you might find additional ligament laxities which you cannot see on the X-rays. And if you are not doing anything to these ligament laxities, in some of these cases, the bone correction will be off and you will have a suboptimal result for your patient. Step number 4, the definition of your deformity and also the aim of correction. In some of these patients, the aim is not to go to the Fujisawa point. There may be an aim of your correction where you only have to correct to symmetry. After a trauma, the patient just wants a leg back that's symmetric in slight varus, for example, to the other leg. So if you aim for a correction that is always in valgus because you're doing a high tibial osteotomy, that's not the good aim. So the definition of the deformity and then the aim of correction. Then you do your planning of correction. And look at number 6, implant selection. We often do not have a choice of many different implants. However, some of our deformity corrections, these patients need different implants than you normally use. There are sometimes better implants, or you need an X-fix or any kind of implant that is not standard in your hospital. You should weigh that in your whole plan and give it an important part at the end of your plan. And the final step is the description of surgical tactic. Now, what is that? Look first to this girl before I come back to the description of the surgical tactic. And we're looking now at the correlation of physical examination, gait. So this young lady was sent in because she has a valgus problem. We will see her later in another presentation, but I just want to show you that this young lady doesn't have a valgus. So something else is going on. So you wouldn't know that she has a straight leg alignment only from her video. So you have to correlate things here. You have to examine, you have to look at X-rays, correlate that to your physical examination. And again, we will see this young lady later on in one of the other presentations. Now here's the surgical plan again. This was on correlation of physical examination and radiological deformity analysis. Now look at this case. This is a 54-year-old lady. She had a flexion osteotomy because she was having severe hyperextension. This has been performed many years ago. When she comes to the clinic, she is able to do a full extension of her knee. If you look at that slope of 51, and I already tell you that a normal slope is not 51, but 80, 82, 81 in this kind of measurement. So she has 30 degrees abnormal slope. Then you have to realize that if she can fully extend the knee, she still has a severe laxity problem. She still has her posterior capsule very lax. So this is out of Paley's book, some drawings of a similar case that was simulated there. And if you correlate the examination findings, having her a full extension of the knee with the deformity analysis, you realize that you have not only a bone deformity, but you also have a ligament deformity, the posterior capsule. And that's also called a deformity, a 30 degrees joint laxity compensation. So this is a osteoarthritis, which has to be treated with a total joint replacement. You better choose a hinged implant at that time. And this case, to get that implant in, we did an anterior closing wedge, hence you see the staples there, to make that plateau flat again. The minute you make that, you correct that plateau in the sagittal plane, you have a 30 degrees hyperextension back again. And for that, it's mandatory to use a hinged prosthesis. This could only be known with a proper planning according to a surgical plan. So it's very important to correlate what you see on X-rays with your physical examination as part of the surgical plan. Now, what about this point number 7, the description of a surgical tactic? Description of a surgical tactic are the final questions before you go to the surgery. Is the proposed osteotomy site surgically accessible? Like, is it full of scars? Can the plan be carried out using intraoperative guides to enhance your accuracy? Or do you need PSIs or these kind of tools to work there? Is the location of the cuts biologically reasonable? Some of these cases, specifically the post-traumatic cases, you almost do not have an entrance, or you should switch from entrance because of the soft tissue scarring, neurovascular bundles that are compromised, or previous musculocutaneous flap surgery. Is a stable fixation possible with the fixation method you choose? Normally at step number 6, you should have made your decision there, but still it's also important to check that before you go to surgery and probably have an alternative on the backhand. And then, can the soft tissues withstand the degree of bone correction anticipated? So sometimes you have to just stick with a partial correction because it will otherwise, the soft tissues cannot withstand the total correction. And that's very rare, but if you do not anticipate on that, you will have big soft tissue problems after your correction, and the patient has the biggest problems. So these are all very important things to think over before you step in that OR and to finalize your surgical plan. Now look at this case. This was a case, motor vehicle accident, very disturbed fracture healing with also a lengthening procedure, infection, and this type of soft tissues the patient was left off with. And then he just didn't want to have any surgery for the next 5 years. And now he comes to the clinic with a medial pain, medial osteoarthritis. And he tells me, oh, by the way, my foot is pointing inwards. So what do I do? Well, if you look, you see severe soft tissue scarring. There is a rotational deformity, and there is varus osteoarthritis. You see a weight-bearing line that is in varus. So if you want to do a correction of 2 things at once, varus to slide valgus, to unload the medial compartment, and a rotational correction, how do you do that? Where do you do that? So this is just to go step by step on how you can think of a case like this. Here we go. Physical examination, normal as expected. Of course, an in-toeing gait on one side, malunited fracture in internal rotation, and also varus. Radiological analysis you have seen already, and we have the CT scan there. If we look at the correlation, we see a 10 degrees of varus osteoarthritis, 20 degrees of internal rotation deformity, and severe soft tissue scarring. We have a definition of our deformity, and this is our aim, a valgus unloading and extension, external rotation osteotomy. That's what we want to reach. How do we reach that? How do we plan that? Well, this is the situation. We have tibia proximal, shaft, distal, and where can we make our osteotomy? Proximal, on the lateral side, I don't want to go. Shaft, I don't want to go anywhere there because that's bad bone healing. And how do I correct both planes there in the presence of that soft tissue? Do we go distal? Well, distal seems reasonable because we have good soft tissues distal. However, how do we correct the varus? Why don't we think multi-level? That was the choice. And then we have also made our decisions on plate fixation, and you're going to see what we have done there. And of course, most important, we deal with the soft tissue scarring. And the final conclusion of this surgical plan was we go double level. We do a proximal open wedge high tibial osteotomy to unload the medial part of the knee for the varus osteoarthritis. And we do a distal tibia and fibula rotational osteotomy. That's where the good soft tissues are. They can withstand these kind of forces and stretching. So then I was talking to my plastic surgeon, and just to ask him, can I do this with the soft tissues? And he says, you go for a preconditioning. And I didn't know what that was. A preconditioning is you make a scar, you develop your approach until the level where you want to go, and then you close. And I say, I beg your pardon, you're going to close? Yes, you're going to close the wound again and you let it heal. And then if that's good, then you know it's vital and you can go there for a second time. So that's what we did, step number one. And the patient was fine with that. So after 6 weeks, we did the double level osteotomy, the multi-level, and this was the result. Open wedge medial, external rotation, distal tibia osteotomy and fibula osteotomy, and plate fixation at 2 levels. And this is the result at the end of the surgery. So this is surgical planning. This is advanced osteotomy planning. And this is just an example of many of these cases who need this extra kind of planning. Now, there also is a need sometimes for complex x-rays. You can all find that, how to do with that, deal with that in the book of Paley, who has excellent descriptions and illustrations of that. Just an example. This is a case of post-traumatic and congenital deformity combined. This patient deformity is in an oblique plane. Actually, that's the case in many road traffic accident malunions in lower legs. So you have to be careful that you analyze all the planes. And this is just an example how with x-rays you can find the plane where you need the correction to be performed. But you need to make specific x-rays. And these are specific x-rays to find which plane shows a straight bone. From that, you can find the plane of your correction. So here we are, the oblique plane, and the oblique plane deformity gives you a straight bone, and from that you can make your osteotomy plannings. And I'm not going to go very, very deep into that, but you have to realize that these oblique plane deformities exist. This is an example and how you can correct it with an oblique osteotomy. We have a combined valgus and external rotation tibial deformity. And there on the lower left corner, you see the planning x-ray. This is an oblique plane osteotomy. The ruler you will see later on in the rotation osteotomy talk, and we make an oblique plane ending underneath the tuberosity, and then while internally rotating the leg, we immediately also correct the valgus. And after that, we do a, and you see the K wires here, 18 degrees off, and after the rotation, you have a straight leg with the K wires in the same plane. So both deformities are corrected by one movement. And you can only find out how to do that when you make these oblique plane x-rays. Now you can go from periarticular to shaft deformities, and there's also CORA and the osteotomy rules. That is not part of this presentation. We are talking about other kind of deformities, especially at the shaft level, but I want to mention that sometimes in multi-level deformities, you have to be aware that you have to deal with a combination of periarticular deformity as well as shaft deformities. And then rules like osteotomy rules, CORA, and ACA, angulation correction axis, play a very important role. So you have to think of your knowledge on that topic if you have multi-level deformities. Take-home messages on advanced planning. Full leg weight-bearing x-rays are mandatory for planning, and please put the patella forward. Deformity analysis according to Paley is recommended. The manual planning according to Miniaci, which has been taught to you by Dr. Christian Klei last session, the webinar 2 weeks ago, is recommended. We describe these plannings in all our books and all our publications. Planning of an open wedge and a closed wedge is possible at the femur and the tibia, and deformity analysis always before planning to find the location of correction. Planning is more than repositioning weight-bearing lines. I hope that's very clear now. Make a surgical plan, especially if this is an advanced case with soft tissue issues bothering you. Correlate physical examination with your radiological deformity analysis and look at the joint line orientation. And the planning with ACA and CORA is a planning which is most important when you have shaft deformities. Finally, plan every case and evaluate your planning. So this is to the first topic, advanced planning.